Good afternoon again. My topic is cataract and irregular astigmatism. Here are the financial disclosures. I think this is not relevant in terms of this particular talk. Now, if we would like to start with correction of astigmatism, I think that nowadays we have to correct astigmatism with toric lenses because this is a big advantage for our patients. If you look at the literature, there are two main papers which have summarized this. This is a toric intraocular lens paper, and basically what their three randomized trials have found is that toric lenses are better than monofocal spheric lenses. And you see here all these four topics: better uncorrected distance visual acuity, less spectacle independence, no increased risk for complication, and less reduced astigmatism. There's a follow-up study, also 2 years follow-up, and basically what you see here, you get an astigmatic reduction of more than 70% if you perform toric lens implantation. The question always is also, if we talk about astigmatism, then where to correct. Low astigmatism, there are now ideas out that we even go down to 0.75 for correction of astigmatism when we have toric lenses. Particularly, this is very important for multifocal intraocular lenses. Just as a start of my discussion, I think we actually doing this below 0. So to get the astigmatism to 0.5 diopters. Now let's go to the types of astigmatism. First of all, regular in terms of against the rule, with the rule, and oblique, if you can see this here on the topography. Just this slide demonstrates you that if you want to do this surgery, you have to have a topographer, a tomographer in order to recognize what you do. So in modern surgery, when we even talk about regular or irregular astigmatism, a tomographer is mandatory for your day-to-day work. You see here against the rule, with the rule, and oblique astigmatism. Beatrice showed this slide in her previous nice lecture on the multifocal and EDOF lenses. And again, you see that in our population, we have only 58% below half a diopter, meaning that approximately 30, 35, 40% are above this diopter, and one diopter is less than 1 diopter, 70%. Now, of course, the problem comes when it is now to irregular astigmatism. And we can have several types of irregular astigmatism, which I have listed here. Ocular pathology, for example, in keratoconus, in PMD, sometimes even dry eye syndrome, post-refractive surgery, then, of course, after penetrating keratoplasty, and maybe the worst is sometimes trauma. Here are some of examples, again, of irregular astigmatism. Form frust in the lower left bar, right, post-myopic laser, an older profile, optical zone, medium optical zone size, post-hyperopic LASIK, older profile with some irregular cornea, and then on the right side, lower bar, penetrating keratoplasty, again with astigmatism, but irregular. Now, if you look at irregular astigmatism, patients with irregular astigmatism also desire the best vision possible and spectacle independence if they got cataracts and they have the cataract removed. However, the irregular astigmatism can pose a significant challenge for us. Careful consideration of the etiology of the irregular astigmatism when decided on the optimal treatment strategy is therefore very important. Corneal versus irregular ocular astigmatism, we just need to always understand internal is not the external astigmatism. The preoperative corneal astigmatism is not the postoperative. Just think about doing surgery in a post-penetrating eye where you have some irregularities, biomechanical instabilities. If you have incisions which are large, then you change the astigmatism. Astigmatism of the IOL plane is not the astigmatism at the spectacle plane, important. And then also, this was also touched previously very shortly, now we have to consider the posterior astigmatism because we would like to correct the corneal, the total corneal astigmatism, and nowadays we can measure this because we know that the role of the posterior astigmatism has something to do. Here are some papers, 3 papers out of the literature, which looked at a large number of eyes, and unanimously they found that the posterior astigmatism is -3 diopters, not much, but basically there is a standard deviation. We looked at this as a two papers. One was on our regular patients, total corneal refractive power in 3,800 healthy eyes. We looked at the anterior, the posterior, simulated keratometry, and the total power. And the mean magnitude, as I mentioned, was minus 0.33 diopters. What is important is if you look at the posterior, you don't find the same in the interior and the posterior. So when the cataract, or when the patient had an anterior with rule astigmatism, most of the time posterior was the same. When it was oblique, we had a mixed 79 with the rule, 18 oblique. And if patients had against rule, then it's even become worse. Now, if you look at irregularities, you see here the keratoconus eye. Again, we can look at these pictures and we would like to understand how they are influenced by the posterior astigmatism. We did a study published just recently, 2017. It was a retrospective cohort study of keratoconus eyes. And we looked at the magnitude of astigmatism and found at the anterior part 3.47 with a huge standard deviation, of course, with keratoconus. And the posterior surface was 0.69, which was much higher than we found in our patients with regular astigmatism. In eyes with keratoconus, a match between the anterior and the posterior alignment, when alignment was vertical in 97% of eyes, 46 when oblique, and 61 when horizontally. And also we found that with progression of the disease, the alignment of the anterior and posterior corneal astigmatism became increasingly vertical. So in summary, here the posterior is important. In keratoconus eyes, we can use this for becoming better in our outcomes. Another case of irregular astigmatism, PMD, as you can see here again with a tomography map. And I think it's important to get this information now rather than just to look at the placebo images because they only give the anterior part. Dry eye syndrome, also some kind of irregularities, can be very important for trifocal, for depth of focus IOLs because you have to treat this. And post-penetrating keratoplasty, as was just also shown in the previous talk, you have irregularities. Now it becomes very difficult to correct this. If you look again at the ocular pathologies, which I showed here in summary, the question is how the treatment options basically exist. So you can do conservative, like spectacle and contact lenses. We're talking about cataracts. This is then, of course, not pertinent to this topic. On the cornea, we also can correct astigmatism, irregular astigmatism with ablative procedures, incisional, and with other procedures like Intex, or we have in a regular patient also phakic intraocular lenses. However, if we remove the cataract, then we have a couple options. Monofocal toric lenses, small aperture, also touched previously. Multifocal toric is a big question here, of course, in irregularity, but if it covers, for example, also dry eye syndrome, then we can look at this. And then I think very importantly, and Beatrice showed this also, is this add-on technology in the future, because this separates the sphere in the base lens from, for example, the astigmatic component in the second lens. If you look at cataract surgery in eyes with keratoconus, a review of the current literature, what they found is that there is an increasing number of keratoconus eyes requiring cataract surgery. The review also showed that the planning is important, the use of stabilizing procedures might be important, and the decision on intraoperative wound construction and toric versus monofocal lenses becomes important more and more as the severity, regularity, and the central nature of the cornea and post-op use of rigid gas permeable contact lenses can still improve, but of course we would like to achieve this with our procedures. The key points is if you look at the stability, severity, as I just pointed out, the preoperative biometry is important. The procedures to cross-link, for example, to stabilize the cone and the irregular astigmatism, and toric lenses should only be placed in the mid to moderate keratoconus patient with the outcome of this paper here, with low possibility of future progression. Keratoplasty or post-operative use of rigid gas permeable contact lenses, clear lenses can also be advantageous. But this was done only for toric lenses which were placed in the capsular bag. And this, of course, has not touched the differentiation between two types of lenses. Selection of patients, we can add toric lenses, or we can look versus limbal relaxing incisions. We usually use now toric intraocular lenses above 1.5. For small amounts, we can even look at limbal relaxing incisions. But of course, we need to have our good methods to measure the astigmatism. Again, I would like to show this quickly. Optical biometry, total corneal refractive power. And if you look at the maps here, you found a discrepancy between this case here, where the anterior is 2 diopters, the posterior 2.1. But there are also cases where you have at the anterior 0.1, at the posterior, the total corneal refractive power 1 diopter. And therefore, the selection of toric lenses becomes a little bit more difficult. Therefore, the new measuring device is very important. And here I show you a case with a astigmatism, torus, keratoconus patient, minus 3.52 in the biometry, just taking with the IOL Master 700. And if you look this topography for the keratoconus patient with the irregularity, you found that in this case, we found only when you measure the total sum, you found 2.9, so a little bit discrepancy with this. In terms of measuring with a pentacam, again here small amounts, higher amounts, and even higher amounts of irregularity. And of course, it becomes important to measure these lenses with the right formulas. Cannot go into this into detail. Again, looking at a high irregular cornea at this point here, you can see here the preoperative examination of this patient. It was a woman of 61. I like to show you this result. Subjective refraction before surgery was 0.4 and 0.3. The right eye was a dominant eye. It has radial keratotomy, so also one type of irregularities, 30 years of age. Patient presented for cataract examination because she had an early cataract, visual deterioration for 3 to 4 years, and had eye drops, just also a pressure lowering device, or basically a drop taking into account having this pressure of 16. So we looked at the IOL master, we looked at the cornea. You can see here some of these regularly or these little scars from the radial keratotomy, and you can see here the other side, which has produced these irregularities on the cornea, which is very difficult to correct. And I also looked at the previous options. Which kind of lens should we now take into consideration? Cornea with very irregularity, no toric intraocular lens is recommended usually. Which IOL, or what would be the next step? Which IOL would you choose then? Monofocal, multifocal, of course not, and EDOF lenses is also a question. But basically, I would also like to highlight the alternatives for the irregular cornea. So you can go with IOL and topography-guided corneal eczema surgery. Here I show you a result where we enlarged a small optical zone following a patient who had myopic PRK. And here you see the enlargement of this optical zone with a good outcome. This is an example of topography-guided treatment of an irregular cornea. And then, of course, which we have already touched, is the add-on technology. And I cannot put this word forward too much. We have now the opportunity to separate the base lens and the toric part of the lens in these patients, and these situations are removable. And finally, the small aperture, and I think this is a very good advantage now for these patients. This is the lens which has been already shown, has been studied in the literature to correct irregular corneas, has been used also for treating presbyopia. But I'd like to show you this picture from the journal Cataract Refractive Surgery, where a patient had small aperture intraocular lens for previous corneal refractive surgery. And as I pointed out, our patient here, which I already highlighted, what we decided not to put any normal lens. We put an AccuFocus IC8 IOL with a pinhole effect. Very shortly, you can see here the surgery. We used a femtosecond laser procedure, which you have to be careful. I like to go quickly through this slide, basically taking out the cataract, put this lens in. But what, of course, is dangerous, you all know this implantation, we actually found at the end of the surgery that one of these radial incisions were stretching, although we didn't perform the femtosecond laser cuts, but still in these irregular corneas, you can have actually this problem. After removing the stitches, basically, which you can see here at 3 months, the patient was very happy with this outcome, correcting these irregular corneas with this pinhole type effect. So in summary and take home, I think that understanding astigmatism, particularly in irregular astigmatism, is very important. You need to differentiate between regular and irregular corneas. Factor in posterior corneal astigmatism, I think, is important nowadays because you would like to correct the whole astigmatism, the total corneal refractive power. And then the toricity of IOLs can be done in different ways. Toric IOLs, you can combine IOLs with surface ablation, with add-on technologies, and with a small aperture. I think that's a really rising star in terms of IOL technology for irregular corneas in the future. What you unfortunately have to do, you have to look at your own results because every patient has a kind of different outcome. Many of these irregular corneas have unpredictable outcomes, much more unpredictable than we have it in our normal procedures. And finally, don't forget, if you use multifocal lenses, be very careful with irregular astigmatism because it's very difficult to correct. And with this, I would like to thank you for the invitation and for your attention.
Thank you, Thomas. So let's move now to another very common comorbidity, which is the glaucoma combined to cataract. So that's our pleasure to invite Simonetta Morselli from Italy to debate on that. And so prepare already your questions for the end of the symposium because we will open certainly a very exciting discussion on all of these topics.
Thank you to invite me in this symposium. And now we are with the glaucoma. And what we consider when we make a surgical decision in a patient with glaucoma and cataract, we first of all we look at the health of optical nerve and obviously the extent of visual field damage and also the target IOP. The slogan should be the more damage, the lower target IOP. And in my opinion, and not only in my opinion, also in a literature, upper teens after surgery should be good for mild disease, mid-teens for moderate disease, and low teens for severe disease. And there are a lot of diagnostic key tests, and first of all, we consider visual field to assess glaucoma disease, OCT, anterior segment OCT, and not forget to do preoperative conioscopy, because sometimes we forget for it, especially if you want to proceed for ab-internal procedure with the angle procedure, I stand dual blade can-hole core trabectom. And keep in mind that narrowest angles have a graded IOP lowering after cataract extraction. Cataract extraction alone, in most of cases, is enough for closer angle glaucoma. And in this situation, clear lens extraction is warranted. Well, if we wanted to proceed with the angle procedure, we should identify ID collector channels. If we are lucky to have aqueous angiography, we look at this method to understand if there are ID collector channels. Don't forget to consider cornea and combine corneal hysteresis and pachymetry together, because if we have lower hysteresis, we will have thinner cornea and high risk of progression of the disease. Well, okay, we decide to operate patients with glaucoma only for cataract surgery, and we will prescribe drops after surgery. But we will consider target pressure, like I said before, glaucoma progression, tolerability, and compliance of the therapy of the patient. Because if we have a low compliant patient, we will have a more progression, increased cost for the society and also for the patient. Phacoemulsification alone is suggested when glaucoma can be enough controlled by medication, and visual field effect is moderate and not progressive, but look at the tolerability of topical therapy. Sometimes the outcome of surgery should be changed by topical therapy due to conjunctival alteration. Look at this literature. And taking account of markers of ocular surface inflammation in this paper, look at this. After 3 drugs, 3 drops for each day, what is the inflammation in this patient is very high. Don't forget to speak about backup time. Look at this. The breakup time is very affected when the patient use 3 drugs for 3 drops for each day. And also we consider the incidence of the pseudophakic cystoid macular edema in patients that use topical prostaglandin or beta blockers. And look at the prostaglandin orbitopathy. This was a patient that used prostaglandin in this eye and nothing in the other eye. This is partially reversible in some patients if they stop the therapy. Okay, go to the second step. Should I anticipate time of surgery in cataract evidence? May I combine cataract surgery and glaucoma surgery in mild disease? Yes, the second step should be non-invasive procedure combined with mixed mini-invasive glaucoma surgery. What is mini-invasive glaucoma surgery? This is IOP reduction, a Bintanon approach with no conjunctival dissection. There are 2 groups. One is the increasing of aqueous humor deflux, and the second group is with the reduction of aqueous humor production. If we want to proceed in an angle in a trabecular sham canal, we can operate patient by trabectome, eye stent, hydrostent, GUT, or excimer laser trabeculectomy. I have experience with the eye stent, like you see here and in the video. I normally use this procedure combining with cataract surgery or immediately after surgery in pseudophakic patients. Or if we want to obtain a suprachoroidal deflux, eye stent Subrassi pass microstent. Now is not yet available because it's create endothelial cells count defect, but I use it in a past, and in my in my surgery I didn't have any problem to endothelial cells count disease, but the most of my surgery is made by Xangel stent, like you see in the video. I normally combine the surgery with cataract surgery, or after surgery in a pseudophakic patient. I inject 0.5 milligram milliliter of mitomycin C under conjunctiva, in the conjunctival space, and then after cataract I insert Xangel stent 3 millimeter distant from the limbus under subconjunctival space. That's very important. That's the Xangel should be in a under subconjunctival space. Or if I want to reduce the aqueous humor production, I use endocecal photocoagulation or ultrasound disruption of the ciliary body. Well, I have lots of experience in XN45 and a mild and moderate glaucoma patient with cataract surgery. And if I have a failure after the first implantation, I will implant the second one. And if I have also failure of the second one, I pass in a third step or invasive or filtering surgery. Filtering, I don't like to implant valves, but if I have obliged, I use this technique. This is filtering trabeculectomy surgery. This is a mini-invasive trabeculectomy surgery because the hole is 1.5 millimeter, but it's a classical trabeculectomy. This should be applied also if you first approach the mix surgery. Well, when making surgical decision with the glaucoma encounter patient, we balance very well safety and efficacy. Safer procedures have lower efficacy, obviously. If we perform trabecular canal-based procedure with cataract surgery, we will safer, but we will have less efficacy after surgery. If we apply transcleral, we will have more efficacy, but more risk, and we take care much more for in a time the patients. But anyway, anytime risk of procedures does not exceed the risk of disease. In conclusion, use diagnostic testings to stage disease, guide target IOP, and identify which surgery procedures are indicated for your patients. There are many exciting, unique procedures can be overwhelming for glaucoma specialists. Ignoring mix is not the answer. Become familiar with accessing all the space of the eye. Know what you can do and when to refer out. Assessing and addressing glaucoma in the cataract patient is critical to a successful outcome. Early intervention with a stepwise treatment, like I said before, approach should be considered in all cataract patients with glaucoma. And thank you very much for your attention.
Simonetta, thank you. Thank you very much. Your talk is followed now by Nick Reus from the Netherlands. His topic is cataract and macular degeneration.
Good afternoon. Thank you very much. Cataract and age-related macular degeneration, they often coexist because the older we get, the bigger the chances that we have both of them. These are also both of the most prevalent causes of visual disabilities in the Western world, cataract and macular degeneration. So, in macular degeneration, how to make the indication for cataract surgery. And you also, with every time you put someone up, you list someone up for surgery, is the question, will this patient benefit from cataract surgery? And in patients with macular degeneration, it depends on the type of cataract and also on the severity of the macular degeneration. So is it nuclear or cortical or a posterior subcapsular cataract? Especially with posterior subcapsular cataract, people have a lot of complaints of glare. And also with cortical cataract, it is the case. So in these types of cataract, it may be very beneficial to do the surgery. With the nuclear cataract, it often decreases your visual acuity, your contrast sensitivity, and that's also something which is lost in macular degeneration. And for the severity of macular degeneration, if it's early or moderate or severe, later geographical atrophy, or a exudative macular degeneration, you have to take that into account. And for that, you have to make an OCT or a fluorescein angiography. Various studies have been performed on cataract in macular degeneration. And what all studies show is that in patients with AMD, cataract surgery improves visual acuity and improves visual function by means of patient-reported outcome measures, like the CATQuest and the National Institute Visual Function Questionnaire. And although they gain in visual function and visual acuity, it is less than if you have no retinal pathology. And one study found something very interesting, I thought, is that if your visual acuity is above 20/40, 0.5 Snellen visual acuity, then patients with macular degeneration have a similar improvement to patients without retinal pathology. If preoperatively they have a visual acuity less than 0.5, less than 20/40 vision, then the worse the visual acuity pre-op, the worse the outcome. But still, they benefit with surgery. And only in advanced AMD cases, the cataract has to be very severe for the patient to benefit from the surgery. Another thing is, and this has been debated for a long time, a lot of studies have been carried out in this, does cataract surgery increase the risk of progression of macular degeneration? And a couple of decades ago, several studies came out with conflicting results. And since then, new studies have been performed and meta-analysis of the studies have been performed. And based on these results, in general, in dry AMD, there is no increased risk of progression to exudative AMD. Similarly, there is no increased risk of progression to early or moderate AMD. There is a possible increased risk of progression to late or geographical AMD. But various studies give conflicting results in this. And that might be because of different kinds of patients that have been entered in these studies. Now, what if you have a wet AMD, an exudative AMD, if you are going to operate it? Well, from the Anchor trial and the Marina trial, when they looked at the cataract surgery in the patients in these trials, it became aware that if your exudative AMD is well treated with anti-VEGF, so you have there's no subretinal fluid anymore, then there's no progression with cataract surgery. There is a study, and this has not been studied extensively, cataract surgery in wet AMD, but there's a study that looked at patients who were treated for exudative AMD with regular intravitreal injections. And what they found is that after surgery, the thickness of the macula increased and there were more cysts. Not cystoid macular edema, but several cysts in there. And this suggests that close monitoring of these patients is mandatory after surgery. And this is also that we do in our clinic, that we monitor these patients very well. For example, this is a case of a patient pre-op, had no subretinal fluid. He was in a treatment for exudative AMD with periodic intravitreal injections. Then he had surgery, and 3 months after surgery, there was some fluid in the retina, some exudation, and then we gave an intravitreal injection again, and the fluid disappeared. So it's very important to closely monitor these patients after surgery. Then another thing is the choice of IOL, and this is also much debated. What kind of an IOL should you put in, and especially the color of the IOL? And this is that with cataract, you have a yellow lens, and this filters the blue light. And many people use clear lenses, and although UV light is blocked, blue light is not being blocked, and it reaches the retina. With yellow lenses, there's a blue filter in there, UV light is being blocked, and also part of the blue light is being blocked. And the question is that better for the retina? Now, in an animal model, and this was published in '66, they had a lamp with high intensity blue light, and they shone it on the eyes of rats. And what they found is that the retina was destroyed by the high intensity continued light of the blue light. And there came the possibility that filtering blue light in IOLs might protect the retina. But blue light's also important for scotopic vision and also important for circadian rhythm, for our wake and sleep routine. And this is a picture from Mainster. And here you see the wavelength of light versus either the sensitivity of the photoreceptors or the transmittance of the IOL. So this is the green light with the peak at 500 nanometers. And this is important for scotopic vision. Here, the somewhat green lights for the photopic vision. And this is our blue light, which is important for our circadian rhythm. And this line represents a lens, a clear lens that filters only UV light you see that the blue light is transmitted. But when you have a yellow filter in it, then part of the blue light is being blocked. But that may affect your circadian rhythm. A yellow lens that we implant has a similar transmittance as the lens, as a phakic lens of a 28 to 30-year-old subject. So this is a lens that is not really yellow, it's a bit yellow. So probably the difference between a clear lens and a yellow lens is not that big for the human eye. And the problem with the studies that have come out is, and recently a meta-analysis and a review of all the literature that is out there concluded with the fact that based on the current best available clinical evidence, the effects of blue light filtering IOLs on retinal health and function, both positive and negative, remain unclear. So probably the effect of a clear lens versus yellow lens is not that big. But if there is an effect, it might be a bit more protective for the retina, but you have to be aware of possible influence on the circadian rhythm. Now, another choices of IOL, macular degeneration affects visual acuity and contrast sensitivity. So, when choosing an IOL, you have to choose an IOL of good contrast sensitivity and low light scatter. So, in general, a monofocal or a toric monofocal are good choices, but a diffractive multifocal lens is a bad choice in these eyes. I think also a toric lens can be used in these patients, maybe advantageous. And of course, it depends on the visual acuity that you expect the patient will have after surgery. So, if, for example, if you have a cylinder, and this is a table from Wolfson, if you have no cylinder and you would have a Snellen visual acuity of about 1.2, if you were to introduce a cylinder in the eye, then uncorrected, you would lose some lines and would have a visual acuity of 0.9. So if you have an early or moderate AMD, these kind of lenses may be very advantageous for uncorrected visual acuity. But if you have an advanced stage of macular degeneration and a small amount of toric, of cylinder, then these lenses may not be advantageous. So you have to take into account the expected visual acuity that the patient will have. There are also special lenses for AMD, and in general they provide magnification for improved near vision. Problems with many of these lenses that used to be marketed are that they are very large, and you need a large incision, and with the large incision and the large lenses, there's a subsequent loss of endothelial cells. And that may be a problem also in these eyes, so they don't just have macular degeneration, they also have a compromised cornea then. A recent lens that's on the market is the Chariot macular lens. This is a refractive bifocal IOL. It's an add-on lens for the sulcus, and centrally, in the center, it has a small refractive power of +10 on the eyeball plane. And that gives a reading addition of about +6. So it's at 15 centimeters near. And what will happen in these eyes is with your advanced AMD, people won't see part of the center. And with this reading addition, and you take the book closer by, you will get a magnification of that. So it's easier to see the letters through the damaged retina. One more thing is dealing with the lens touch. So all these patients getting all these intravitreal injections, about 1 in 1,000 times the lens is touched. And you have a posterior capsule rupture, a tear pre-existent. And such a pre-existent tear produces a high risk of a dropped lens fragment with dropped nucleus, vitreous loss, endophthalmitis, and possibly also exacerbation of exudative AMD because you trigger inflammation in the eye. So how to deal with this? Well, do not perform a hydrodissection as you would normally do. Do a hydrodelineation. So inject fluid inside the nucleus and not around the nucleus or the cortex. Try not to do a lens rotation, because rotating the lens will put forces on the back of the lens bag, and it will make the tear worse and make it into a rupture when you have a dropped nucleus. So you can do surgery like in situ nuclear fractus, where you perform either a normal divide and conquer technique, but without rotating the lens, or easier probably is chopping the nucleus. And when possible, if you have a first crack of the nucleus itself, not all the way through, but just the nucleus, inject some dispersive viscoelastic behind the lens to protect the lens from falling down. So you make, like in this image, the purple color is dispersive elastic. You make a cushion of viscoelastic so that the nucleus cannot fall down into the vitreal cavity. Emulsify nuclear fragments whenever possible. If you have taken a small fragment out, emulsify it so it cannot drop to the back of the eye. And leave the epinucleus as a shell at the end, for the end to emulsify it. At the end, I would check for vitreous using diluted triamcinolone alone and implant a 3-piece lens in the sulcus, preferably with an optic capsule. So in conclusion, cataract surgery is effective in improving visual function in patients with age-related macular degeneration. In dry AMD, there is no risk of progression, although possibly a risk of late AMD. In wet AMD, there are good outcomes under anti-VEGF treatment, and most people recommend 1 or 2 weeks before surgery to do an injection with anti-VEGF, but close follow-up after surgery is necessary. A monofocal IOL or a toric monofocal is the best choice in AMD, but special IOLs for AMD and advanced stages may be helpful. And the effect of blue light filtering is not clear. And I think that cataract surgery after lens search remains challenging. Thank you very much, and we look forward to seeing you in Paris in September.
Thank you, Nick, for this very comprehensive approach of macular degeneration. So let's move to something also very risky for cornea, which is the eye myopia. So what about cataract and eye myopia? Eva Murta from Poland will tell us about that.
Good afternoon. It's my financial disclosure. So, according to the World Health WHO, the causes of blindness, the most common causes of blindness is cataract. This is more than 40% of patients. But the second place is for the uncorrected refractive errors, is almost 20%. High myopia is now under the discussion. Many discussion, a lot of discussion we can find not only between ophthalmologists, but also in the literature. On this graph, you can see the number of people estimated to have myopia and high myopia for each decade from 2000 to 2050. The amount is growing and growing. In 2050, the high myopia will be doubled than in 2000. We can ask that, maybe you know this, that the highest value of the refractive error described so far was -50 to -60. And the highest value of the axial length of the eye was 35.8 millimeters. So, this was the case, genetic, high myopia, and was present in the entire family. It was described in 2003. Myopia increases the risk of eye disease. We know that it's more often retinal detachment, glaucoma, myopic maculopathy, AMD, CNV, amblyopia eyes, and subluxation of the lens, and as well as the cataract. The changes in the eyeball in the course of myopia and high myopia we can find in the eye fundus. Most often are the peripapillar chorioidal atrophy and the changes in the posterior and peripheral pool. As well as the vitreous degeneration, such as posterior vitreous detachment, posterior vitreous lacunae, and extensive vitreous liquefraction is accompanied by myopic patients, as well as the glaucoma, cataract, and AMD. But you can see the point of which cataract is the most often in myopic patients, and we can notice that the nuclear in myopic patients is in 40% of patients, in comparison of the non-myopic eyes in 25%. The same is with the posterior subcapsular cataract. You can find this in 26% of myopic patients and in 11% of non-myopic patients. So the nuclear and the posterior subcapsular cataracts are known to be more predominant in myopic eyes. The most important for a decision and how to operate the high myopic patients with cataract, we can tell that the most important is qualification. The cataract surgery in high myopia could be a challenge. The choice of the surgical method includes the changes in the eyeball. The cataract surgery in high myopia required proper planning. First of all, the setting the phacoemulsification parameters, selecting the adequate IOL, as well as complementary treatment of the retinal changes. The qualification criteria for surgery in patients with high myopia and cataract should be taken in the decision on the severity of the cataract, the characteristic changes in the posterior pool of myopic eyes, if we should to operate or not, if there's presence or not the myopic maculopathy, presence of retinal detachment and subluxation lens because of the weak zonules. We can also focus on the calculation of the IOL. The power is critical in obtaining good visual outcomes post-operatively. The mild post-operative myopia is generally recommended for cataract patients with myopia. We can see in the literature some discussion about which one formula we should to use. In eyes with axial length greater than 26 millimeters and IOL less than 6 diopters, the Barrett Universal Second Formula and the Hygis and Holiday 1 formulas should be used. You can find this in most of the article. We can ask the questions: does the reduction of the visual acuity depends on the degree of the lens opacity instead of retinal degeneration of macular degeneration? Is there a risk of subluxation of luxation of the lens due to the zonular weakness? Are the changes in the visual field caused by glaucoma or only myopia? What are the standard procedure if we choose only phacoemulsification or we focus on the pars plana vitrectomy? What are the patient's expectations for improving the visual acuity and postoperative refraction? So when we discuss this with our patient and we qualified the patient, because the qualification is the most important things before the surgery, we focus then on the surgery. We sometimes find the patients who come to us with a cataract, hard cataract, and we cannot notice what happened in the posterior pool. But the visual field could be like you can see here, and you can, after the surgery, find the really disturbed the posterior part of the eye. Possible complications during surgery, we can find the intra and post-operative. The intraoperative, the most important is that you should visualize the surgical pool. So because of deep anterior chamber, the visualization sometimes could be difficult. As well as the fluctuations of the intraocular pressure during the surgery and difficulties in the capsulorhexis. Sometimes we have the decision we should to find the golden mean, and if cataract is too hard, we can have more difficulties. But if the cataract is too soft, the operation may not be needed, and we cannot reach the goal. The problem during surgery could be also the capsular rupture, and we can find this dropped nucleus. A lot of publications focus on the retinal detachment after phacoemulsification in high myopia. I would like to show you this one is described, the analysis was described in 10 years ago, but is the big amount of cases, 2,356 cases, and the authors summarized that the risk of postoperative retinal detachment was significantly higher in eyes of younger patients and eyes with preoperative prophylactic treatment for retinal degeneration. Sex history or laser capsulotomy and increasing axial length had no statistically significant effect on the rate of retinal detachment. The incidence, in another publication, you can find the incidence of retinal detachment in cases was 2.7%. In eyes with age less of 50 years of age was 3.65%. But no significant correlation was found between the occurrence of retinal detachment and vitreous loss or in neodymium capsulotomy. The possible complications during surgery show us that the patients with high myopia is a difficult decision when and how to do the surgery. But the surgeon can find the unexpected situation during the surgery, increased intraocular pressure, corneal edema during the surgery and after post-operative, inaccurate calculation of the IOL power, IOL miscalculating, and then refractive surprise. Post-operative astigmatism, as well as the retinal detachment in every time after surgery. I would like to show you here a short video with the hard cataract and patients with high myopia and myopic astigmatism, who was qualified for the surgery with implanting with toric lens implantation. The most important to visualization of the anterior capsule is when you use the trypan blue. This facilitates very much the capsulorhexis. Then the next step, if you make good hydrodissection, then you divide the lens, the nucleus, and after that, if the nucleus is removed, we should to look at this posterior capsule if it's really needed to clean it. Because during this maneuver, you should to have the most often posterior capsule rupture. So it's not a problem with the lens. In the past, many surgeons decided, like in this case from our archive of our hospital, decide to make this extracapsular cataract extraction in this subluxated cataract. You can see here that it was difficulties in capsulorhexis. You can see here the border of the subluxated lens. And it was much often in this type in the 90s that the surgeon removed the nucleus with this maneuver. But then we can have the problem with last part of this procedure. Sorry for that. And it should be implanted the capsular tension ring to stabilize the posterior, stabilize the lens capsule, and then carefully implanting the lens. But sometimes after the next day after the surgery, the surgeon asks what happened during the surgery in these patients with high myopia, that we have no good visualization, we have corneal edema. And when we look at this posterior vitrectomy, we can see that the surgery was with a trouble that can happen in patients with high myopia. So, highly myopic patients is a difficult decision, and I would like that you take some home message that high myopia is defined as an eye axial length higher than 26 millimeters, and spherical equivalent is higher than 6 diopters. The phacoemulsification is associated with positive outcomes in patients with cataract and high myopia after good qualification. However, it should take into account the risk of possible intraoperative and postoperative complications, and surgeon should be aware of the risk of postoperative retinal tears and rhegmatogenous retinal detachment. Thank you for your attention.
Thank you. We would like to open the discussion to all people here in the audience, and there are some microphones. If you have any questions, go to the microphone, and maybe you can just start. Repeat the question.
It's for you.
Oh, for me. Then I haven't understood the question.
What formula do you use for irregular astigmatism?
For irregular astigmatism, well, we basically go with the same formulas. We go with the new type of formulas, with the Barrett formula, with the RNF, Hill's formula, Olsen formula. So basically with the new formulas. The question is how to determine the corneal power. And if you have determined the power correctly, in stable situations, then it's fine. In unstable situations like keratoconus, and you can do the refraction and you can do the calculation, but you have to be aware of the fact that it will change over time, or could potentially change over time.
If I may add something on that, I think that you can go for toric implantation if the amount of astigmatism measured by the different tools that you have in terms of amount of cylinder and axis is quite correlated between your keratometry measurement, your topography, and your biometry. Otherwise, that means that you're not dealing in terms of keratoconus, you're not dealing with an astigmatism, but more with coma. And so there is no current lenses, of course, who can correct coma. So there is, you need to have this kind of correlation between each of them.
Beatrice, let me follow up on your presentation and for the audience, because you talked about corneal dystrophies. What is your threshold, so to say? When do you still perform a cataract in terms of vision you can see inside the eye? Because for many surgeons, they don't perform. You are an excellent surgeon, and particularly also performing corneal surgery. Not every cataract surgeon does that. So what would you suggest to those situations where you have in kinds of dystrophies, can be on the posterior and the anterior?
So for the posterior dystrophy, I hope that I was clear enough to tell you that there is no reason nowadays not to try to do the cataract first and to see what will happen. So there are some tricks for the cataract, like to use a high viscosity, a viscous of height viscosity to protect your endothelium, to avoid to do a suture. I won't repeat everything that I said regarding that. For the time of the combination, I think that what is really new is not to base your decision anymore on the specular microscopy. And so I guess for me, if the visual acuity decrease below 0.3 with significant, especially in the morning fluctuation, and a thickening of the cornea, so for that we follow the patient, we check them every 6 months, and if we see these kind of changes, we will go for combined surgery. Even if it's needed, refer to a combined surgeon, I would say. Even if it's... So for the anterior, so there are not so many anterior dystrophy. I put together in the same box, I would say, the opacities. For sure, the time for dealing with an opacity and any kind of anterior dystrophy, which can be also irregularities, more depending on the location and the thickness of these opacities, how deep they go. And so the OCT and the confocal microscopy are very supportive to help us in guessing how far we can go if we want to plan, for instance, an anterior superficial keratoplasty, or if we can expect to go behind these opacities with a regular cataract surgery, and I gave you some tricks for dealing with that.
I couldn't agree more, particularly in the posterior, basically in the endothelial dystrophies. What very often happens is the patients become really frustrated when you go below 0.3. They see very well. You do the procedure, and whatever you do, you will still harm the cornea, and the patient had a long-term, like 2 months, corneal opacification because the new techniques have not been used. So I think we both agree that we would earlier nowadays go into this combined procedures, because if the endothelium, even the numbers are there, but low numbers below 500, then you have difficulties post-operatively with a clear cornea, and the patient are frustrated.
Beatrice, have you an indication for the ZEC and the MEC, when you perform the ZEC and when you perform the MEC?
For me, there are 2 key conditions for that. I mean, where you still will go for a DSEC and not a DMEC. DMEC is just the removal of the endothelium, when the DSEC is a very thin layer of stroma that you transfer with it. And actually, it's an ultra thin DSEC now that we are. I think that when the corneal edema is quite strong, and when the anterior segment is challenging, like if, for instance, you need to use an iris claw because the patient has some complicated anterior segment. For me, that's still the place for DSEC. Would you agree on that?
Yes, exactly. My question was, when you have, for example, a decompensated PKP, before doing another time PKP,
okay.
what is your indication?
Yeah.
The macro DSEC or ultra-thin DSEC? Or when complicated patients, for example, complicated anterior segment surgery? Or
so in my hands, it's also depending of the patient's morbidity. If the patient's cataract, a new trial of a DMEC on a PK, that's going to be, of course, tried. But if you know that the patient will have to lay for 2 or 3 days with the bubble, and you're not sure about the results, sometimes I go for an exchange directly. So it's also a question of patient's tolerance and morbidity.
If I understand you correctly, Simonetta, you go for DSEC then, rather than DMEC?
Yeah.
We just published a paper, our outcome was DMEC, and we found really good results when the post-PK with a compensated cornea, decompensated with DMEC.
Yes.
And the corneas were very nice.
No, I agree with you, but the problem is the post-operative management of the MEC, because normally you have detachment of the rate of detachment is higher with the MEC than defects. That's the reason why. And also during surgery, if the cornea is not completely clear and it's cloudy, or if you have some problems in anterior segment with strange IUL or a problem with the iris, the ultra-thin DSEC is safer and permits
the adhesion you get that faster.
Is faster than the MEC. That was my question.
So because 2 girls with the same opinion, which is good.
Exactly.
We don't do DSEC anymore, so we cannot talk about that.
Because you don't have complicated cases.
No, I also do DSEC.
Simonetta, let's talk about the glaucoma cases. The procedure you have shown us nicely now is with the mixed devices. Do you think that in every case where we, for example, have a cataract, the patient has a normal, we're not talking about a flat anterior chamber, we're talking just a normal 24 diopter intraocular lens, and has maybe just taking 1 drop for reducing xalatan, for example, prostaglandin for at night. Do you think 16 millimeters of mercury reduced by 4 millimeters, optical system pretty good, cornea, the optic nerve doesn't show any damage? Do we have to perform then any mixed devices? Would you always, the question is, do you always want to get rid of the glaucoma drops when you do the surgery?
I try to not prescribe glaucoma drops after surgery. And then when a patient suffers from glaucoma, I try to perform non-invasive glaucoma surgery to avoid completely the use of drops after surgery. if it is necessary, I reintroduce drops after surgery, but I try to reoperate patient to not use drops after surgery. And normally,
That means, in other words, that any of your cataract patients who are treated for increase of, you're going for mix, right?
Yeah, for mix, it's dependent on the level of the problem. I perform angular, trabecular procedure or Xengel if the disease is high or...
Is it reimbursed in Italy? Because the economical
yes,
model...
it's reimbursed.
That
Yes.
would have been my question the same,
Yes,
because
it's
that would be
reimbursed.
almost
Yeah,
like
yeah.
every, you know,
type of
4 out of
procedure.
10 patients have
Yeah.
glaucoma drops in ours, so we have to do 4 times mix. 4 out of 10 cases must be combined procedures then.
Yeah. I have patient, for example, with 3 Xengel stents in the same eye. At the end, I was obliged to do trabeculectomy. But anyway, it's reimbursed. That's the reason
That's
why I
completely
use
changing the
all
format.
type of...
Yeah. A question for you, Nick. So we understood, finally, in your hands, after all this literature review that you did so well, are you using blue or not blue? Filter for at least yellow or not yellow IOLs?
Well, I have to say I use both.
Oh, thank you for this very clear question. Answer.
Well, honestly, when we're looking at the literature, I think that the difference is not that big. The reason I use yellow lenses most is for people, for artists who like to paint.
Yeah.
Because when they have the cataract and the cataract removed, the world looks a bit bluish or purplish, and they hate that when they are very critical about colors. And in these patients, I always put a yellow lens in. And that's actually my most prominent reason for implanting a yellow lens.
Funny question.
Is this 1 out of 10? You have
Artists?
We have very,
a lot of artists in the Netherlands,
Yeah.
right?
Netherlands. Did you find any data on the impact on the humor of the patients with the filter? Because we conducted a very funny study in France, multi-center study, I must say, about the effect, the impact on the mood of patients using the yellow IOLs. Did you find something on that?
On the mood of the patient. No, I don't think. I haven't seen a lot of literature on it, but I haven't looked into sleep and to mood literature. What I do think is that, I mean, the yellow lens, the phakic cataractous lens, blocks so much light that even if you put in a yellow lens or a clear lens, the difference is amazing. So I think that's important for your daylight levels. That any lens you put in, it's for the better. And I also think it's good for these patients who have had cataract surgery to go outside again and walk in daylight, because that's the best source for blue light. So they, with their grandchildren who also have to spend 2 hours a day outside, they can spend with their grandchildren outside and they won't have any sleeping problems maybe.
So it's a good transition with myopia.
Yeah.
Yeah, but our neuro-ophthalmological department division make some study about these yellow lenses, and they noticed that 4% from the patients who have white lens have some problems with the blue and violet colors, and these are the patients who have more a concentration of the cone responsible for this wave from our light. So for these patients is for sure add-on lenses should be very good. The yellow add-on lenses we have no on the market now.
Yes,
But
there are
in the
people
future, it could be an option for this patient.
Yes, that there are people who are very sensitive to the blue light.
For the painter, the painter is...
And also there are some studies that that's the blue filter block the melatonin synthesis with the patients. That's the other hand. And the patients that are implanted with the yellow IOLs have some problems to sleep in the night because they don't they don't have enough melatonin inside because the blue filter block the melatonin synthesis.
But the thing is if I mean those lenses, they are comparable to a 30-year-old lens. Well, I'm about 30, but I don't have the impression that a lot of people above 30 have lots of problems with sleeping at night. So I find that's a controversy. Yeah. Yes.
Eva, in high myopes, blue lens or not?
No. White lens.
No? Okay,
White
good. Then
lens.
another question on high myopia. one fine. A big problem is during surgery, usually the fluctuation in the anterior chamber.
Yeah.
If you give some recommendation for the audience, how do you deal with this factor? Because in particular, your 50 myopic dioptic case, it can be a really big problem. What do you do?
Yeah, this is really a problem, but nowadays we have really good devices. We have good phacoemulsificator. So this machine are now protected us. Before it was much more often that you have the fluctuations. Now you have the possibility to make your own parameters, and then you can make lower the pressure, intraocular pressure, and lower aspiration irrigation. So. This is better for.
There is a little trick on that. If you use your manipulator and you keep in bag, just to avoid and to slow down the pressure, the intraocular pressure in the bag, that's very helpful actually to maintain it in a very regular way.
Plus,
so the second hand might be useful.
The incision in proper place of the incision, not too deep.
Okay, so Thomas and dear friends, I think that it's time to conclude. Thank you for attending this session. We hope that you enjoyed this anterior segment debate. And again, you're more than welcome for our big meeting in Paris. We count on you. And we wish you a very pleasant day today and a pleasant stay in Nice. Enjoy the sun, enjoy the meeting. Thank you for attending.